stroke without convincing etiology inform embolism with the likely stroke mechanism. ESUS was introduced in 2014 as a pragmatic clinical construct that facilitated the conduction of 2 RCTs for secondary stroke prevention. Navigate ESUS and respect ESUS. The diagnostic criteria for ESUS is very simple. It is in 4 parts. First, ischemic stroke detected by CT or MRI that is not lacuna. Second, absence of extracranial or intracranial atherosclerosis causing 50% or greater luminal stenosis in arteries supplying the area of ischemia. Third, no major cardioembolic source of embolism. The fourth requirement is no other specific cause of stroke. Accordingly, required clinical examinations are also very simple. Brain imaging, transthoracic echocardiography, 24 hours or more ECG monitoring, and arterial imaging. Based on this simple criteria, approximately 17% of ischemic stroke patients are possibly be classified as ESUS. The stroke recurrence rate of these ESUS patients is 4.5% annually, suggesting the importance to establish secondary treatment strategy for ESUS. As I mentioned earlier, ESUS was introduced as a clinical concept for RCTs for secondary prevention. Then, what are the hypotheses in stroke prevention trials for ESUS? The hypothesis for the RCTs was that covert or subclinical atrial fibrillation, AF, may be the most important underlying mechanisms of ESUS, and thus, anticoagulation should prevent stroke recurrence better than antiplatelet therapy. This is the data from Greece Athens Stroke Registry. In this registry, 10% of 2,700 patients were diagnosed as having ESUS. In the pie chart, you can see many potential stroke etiologies under ESUS. In the Athens Stroke Registry, subclinical or covert AF was detected in 29% among the 275 ESUS patients. It seems that covert AF occupied an important position among the various underlying causes of ESUS. In addition, other potential etiologies such as atrial septal aneurysm, patent foramen ovale, or ventricular non-compaction may also be responsive to anticoagulation. Now, I'd like to move on to the overview of the ESUS RCT as is shown. In this Navigate ESUS trial, rivaroxaban was compared with aspirin for the prevention in patients with recent ESUS. I want to draw your attention to the survival curves of primary efficacy outcome. The primary efficacy outcome in this trial was ischemic or hemorrhagic stroke or systemic embolism. Contrary to the hypothesis that anticoagulation should prevent recurrence, rivaroxaban outcome. Importantly, rivaroxaban was associated with a higher risk. Okay, how about the result of Respect ESUS? This trial compared dabigatran with ASUS patients. Look at the primary outcome. Similar to Navigate ESUS, dabigatran was not superior to aspirin in preventing recurrent stroke. The incidence of major bleeding was not greater in the dabigatran group than in the aspirin group. However, not shown in this slide, there were more. Navigate ESUS and Respect ESUS did not demonstrate a reduction of stroke recurrence with direct oral anticoagulants. Here, I'd like to see the stroke severity in ESUS patient data to think why were these ESUS trials neutral. The median NI stroke scale score of ESUS patients was 5 in Athens Stroke Registry, compared with the median score 13 of cardioembolic stroke patients. The median NI stroke scale score in the Navigate ESUS and Respect ESUS was even lower, at 1. ESUS is mild and seems phenotypically different compared with stroke patients with AF, in whom left atrial appendage thrombi embolized to cause large strokes. Many ESUS may be caused by relatively smaller emboli from valvular and arterial sources. Covert AF in ESUS may be less important than initially conceived, and this may explain why the ESUS trials were neutral. This figure explains the potential embolic sources in ESUS with highlighting the expected responses to antithrombotic drugs. The potential sources which likely respond to antiplatelet drugs are listed on the right half. Atherosclerosis and vasculopathies may be treated with antiplatelets. On the left side, embolic sources that may be treated with anticoagulants are listed, including atrial cardiopathy, subclinical atrial fibrillation, patent foramen vale, or silent myocardial infarction. We can directly understand from this figure that the various embolic sources exist under the umbrella of ESUS. Also, the importance of conducting more detailed workup and more accurate patient selection are suggested by this figure. Before moving on to case presentation, I'd like to summarize the main points. ESUS represents patients on non-lacunar ischemic stroke with no Navigate ESUS and Respect ESUS did not demonstrate a reduction in stroke recurrence with direct or the seemingly disappointing trial results shed light on the importance of a more detailed approach to ESUS. I'd like to present a typical case here. A 76-year-old woman with no AF, no prosthetic cardiac valve, and no ischemic heart disease arrived at 2.5 hours after symptom onset. Her main symptoms were aphasia and right hemiplegia. NIH stroke scale score was 21. Diffusion-weighted MRI showed an acute infarction at the left MCA territory, and MR angiography showed left MCA M1 occlusion. Immediate intravenous thrombolysis and mechanical thrombectomy resulted in a complete reperfusion. Then, is her stroke classified as to be ESUS? Let's check the diagnostic criteria. First, ischemic stroke detected by CT or MRI that is not lacunar. Yes, this patient had non-lacunar acute infarction MRI. Second, absence of extracranial or intracranial atherosclerosis causing 50% or greater luminous stenosis. Yes, you can see that post-thrombectomy angiograms show no significant arterial stenosis. 12-lead ECG showed no evidence of recent myocardial infarction, and 4-week ECG monitoring did not detect paroxysmal AF. Transthoracic echocardiography demonstrated normal left ventricular ejection fraction, normal left ventricular wall motion, and no valvular abnormalities. So third and fourth criteria were also satisfied. The patient was easily diagnosed as having ESUS. Certainly the patient was diagnosed with ESUS. However, as we have seen, ESUS definition alone cannot serve as a therapeutic guide. What is the optimal antithrombotic treatment for secondary prevention in this patient? This patient may have undiagnosed aortic mobile plaque. How about the patent foramen vale? If the patient has subclinical atrial fibrillation, oral anticoagulation may be effective antithrombotic treatment. Transesophageal echocardiography is one of the good choices for more detailed workup after ESUS diagnosis. This patient had no intracardiac thrombi, no left atrial appendage spontaneous echo density, no Chiari network, and no patent foramen vale. Aortic arch atherosclerosis was noted but was not clinically significant. 24-hour Holter ECG demonstrated frequent premature atrial contractions. In addition, natriuretic peptide levels were clearly increased. Subclinical atrial fibrillation was considered as the most likely embolic source in this patient, and oral anticoagulation with warfarin was started. Moreover, to find covert AF, implantable cardiac monitoring was started. There are many implantable cardiac monitoring devices approved. During the follow-up, paroxysmal atrial fibrillation was detected by the implant, so oral anticoagulation was changed from warfarin to apixaban. There have been no recurrent stroke during the 1-year follow-up after stroke. There are ongoing RCTs on ESUS, but these trials are for ESUS patients who likely have embolic sources with potential responsiveness to anticoagulation. Arcadia trial investigates whether ESUS patients with atrial cardiopathy respond better to apixaban compared with aspirin. Atticus trials is for ESUS with left atrial enlargement, patent foramen ovale, or high risk of AF. These trials may open up new strategies for future ESUS treatment. I'd like to finish by making the following points. Pathophysiological heterogeneity under the ESUS umbrella would be the reason for no reduction in recurrent stroke with anticoagulant in the two RCTs. Now we know that ESUS definition alone cannot serve as a therapeutic guide. However, it remains highly likely that improved patient selection and development of more tailored therapies to specific ESUS mechanisms will lead to further reduction of the stroke burden. That's all I have to say. Thank you for your attention.
Thank you, Dr. Tanaka. Let me see the question. No question from the audience. Then I'll ask a question. In the clinical field, usually, what kind of medication do you prescribe for ESUS patient? First.
First-line treatment for ESUS patient.
Mm-hmm. What do you prescribe? Antiplatelet or anticoagulant?
In Japanese guideline for stroke treatment, aspirin is selected as the first-line antithrombotic treatment for ESUS patients. But in the clinical practice, if the patient is diagnosed as a stroke caused by the small emboli from the valvular or atherosclerotic plaques, I use the antiplatelet therapy. But if the patient has a major stroke with large vessel occlusion, this patient may have the cardioembolic source. So I will choose the warfarin for anticoagulation in such a patient.
Okay, it depends on situation and intuition. Okay.
I think that it should be depend on the situation of the patient.
Okay. And the second question is, you commented about implantable cardiac monitoring.
Yes.
And how many portion? How much it contributes to improve the diagnosis atrial fibrillation in ESUS?
I'm sorry. So the improvement of the diagnosis covered F. You mean the?
How much more the patient can be diagnosed as having atrial fibrillation?
I'm sorry, I don't have the right the correct rate of the diagnostic rate.
In it for the study, okay?
Yes, under the study.
For a good lecture, can I check how many investigations should we do to work up ESUS patients? Do we have to do CTAP to look for malignancies if patients are symptomatic? Do you hear me?
Yes. So the question is about the CTAP.
CTAP. What does it mean?
What is CTAP? CT angio. I'm sorry.
I think it's CT. It's tomography for looking for malignancy, hidden malignancy.
The computed tomography with enhanced computed tomography is very important diagnostic tool to detect the occult cancer that may be related to the patient stroke mechanism. Yes, it is. But I think that to find the adenocarcinoma in the liver or within the abdominal cancer. So the abdominal echocardiography is also important to diagnose too, because and the CT may be superior to detect the adenocarcinoma in the lung. Okay.
Okay. I think the blood tests such as tumor marker can be a good clue to find the hidden malignancy.
Yes,
Okay.
maybe good clue.
Okay. Next question. Yeah. How do you think about future therapeutic strategy for ESUS after consecutive failures of using NOACs? Given the result of COMPASS trial using low-dose NOAC plus aspirin, it would be more reasonable to use low-dose NOAC plus antiplatelet agent to curb the recurrent ischemic event from ESUS.
Yes, it is a very fascinating choice to select the low dose DOAC plus aspirin, and I think that the one RCT to test the efficacy or safety of this regimen maybe maybe performed. I think under recruiting the patient.
Okay, thank you. Then the next question. How often PFO is the ultimate cause of ESUS in your clinical experience?
I'm sorry, excuse me.
How often PFO is the ultimate cause of ESUS in your clinical practice? It means, how often do you find PFO in ESUS patient?
Here.
How often?
How often?
Can you find PFO?
PFO.
Yeah.
Okay. So the PFO rate is slightly higher than the general population in ESUS patients. So in our institution, so almost all the patients with ESUS undergo the transesophageal echocardiography, and I think 40 or 50% patients have a small to large PFO. So it is difficult to rightly diagnose the relationship between the presence of PFO and the stroke etiology, but many patients have the PFO in ESUS patient.
Okay, you have a comment. Current ongoing trial of loop recording. Yeah, if time is limited, then thank you, Dr. Tanaka. Good night.
Thank you.
Thank you.